Yeah, good afternoon. So just on a lighter note, an 80-year-old gentleman, 70 late, senior citizen, walks into a pharmacist shop and asks for, 30 tablets of tadalafil. He says, I just have one request. The pharmacist is very much impressed. यार 70 year क्या जिंदा दिल आदमी है सर दीपक जुबानी का lecture सुन के आए लगते हैं. He is very happy. He says, I have one request, just make them, divide them into 1/4, 1/4. No? 1/4, 1/4 करके मुझे दे दीजिए 30 टेबलेट. बोले अंकल ले लीजिए कोई प्रॉब्लम नहीं. It's a very safe tablet. You can easily take whole tablet. Nothing is going to happen to you. Why? No, please do it 1/4. अरे अंकल ले लीजिए आपको you will have a good thing. It is going to सर ने बोला 36 weekend तो पूरा रहेगा. You can have one tablet and it will last the whole weekend. अरे बोले इसके लिए नहीं चाहिए यार. I just want to stop pissing on my feet. I just want it sufficiently up so that it goes into the toilet bowl. So I am a surgical gastroenterologist. I would like to thank Dr. Akash, Dr. Kamaldeep and the entire organizing for this opportunity. I feel a little bit like a fish out of water because I am a surgeon going to talk about the medical management of adverse outcome of a surgical procedure to a hall full of physicians. So let's hope, I am able to fulfill the expectations. The talk that I've been given is medical management of weight regain after bariatric surgery. We do a fair amount of bariatric surgery now. The awareness is quite good. And a lot of patients, since of course now it's already covered under insurance, so we get a lot of patients which we are also doing under insurance coverage. And in India, bariatric surgery is really catching up. There are a lot of options available. I'm not going to talk about bariatric surgery. This is my disclaimer slide. No conflict of interest to be declared. I'll be talking about a couple of brands of medicines, but then they are simply for information purpose, no promotional purpose, and I don't have any arrangement with any of the companies manufacturing these brands. So bariatric surgery is, of course, we all know that it's one of the most effective measure to achieve, lasting weight loss in the morbidly obese population. Commonly we do, especially in Gujarat side where and in India, the most commonly performed procedure is sleeve gastrectomy, but in a selective few patients, depending on the various comorbidities present and what are the patient's what the patient wants to achieve, we also do two more procedures which are bypass procedures, Roux-en-Y gastric bypass and a mini gastric bypass or a single anastomosis gastric bypass. Let us not talk about all these surgical procedures. Let us first define what is the weight loss that is required. So there is a lot of confusion about this. Any procedure, whether surgical, medical, endoscopic, for weight loss surgery, it has been defined that it should have at least 50% of the excess body weight loss should be lost, and that should be maintained to be termed as an effective weight loss procedure. But for weight regain, there's a lot of confusion. Different definitions are there for what can be classified as weight regain after bariatric procedure. It is also known as surgical recidivism, but we'll stick to the common terminologies like weight regain. And among all these definitions that I have mentioned, a weight regain of 20% of the maximum weight that was lost till before the patient reaches the lowest point of the weight, that is the nadir. That correlates best with all the parameters like hypertension, comorbidity correction, improvement in health of the patient, overall mental health of the patient, and the satisfaction with the surgery. Some papers stick with 25%, but majority of them stick with 20% of the excess body weight that was lost, and then again it was regained. So a weight regain after bariatric surgery is the norm. It's not an exception. All patients will regain some weight at some point of time once they have the bariatric surgery. I'll show you the graph. Almost all of them have exactly the similar graph. The curve of the graph and the slope of the graph may differ, but the shape of the graph remains more or less equal. And this has been shown in various studies. There was this very large lab study from USA which showed that, maximum weight loss happens within the first 2 years after the surgery. Then the patient start gaining weight, and about 4 or 5 years, the weight is regained, and then it stabilizes and reaches a final plateau. This was a similar sort of findings were reported from a Swedish study, the SOS study, and it was also reported by an EPSOR group which is from India. So this is a typical graph that you will see that after on the left side, the y-axis gives you the months after surgery. it gives you the percentage of excess body weight loss, and the excess is the months after surgery. So up to 1 year, that is up to 12 months, there is a steady weight loss. Every month, the patient loses 7-8% of the excess body weight loss. Between 1 to 2 years, it reaches a sort of plateau. That is the nadir, that is the plateau, weight loss plateau. It is very important to identify this weight loss plateau if you want to successfully treat the weight regain or reduce the weight regain. And after this, if untreated, the patient starts gaining weight gradually. And then by around 5 years, between 5 to 10 years, this stabilizes and the patient will maintain that weight. Now the plateau may differ, the slope, the gain in the weight, the pace with which the weight is gained may differ, but all of them will have this particular slope, this particular graph. And irrespective of the surgical procedure we do, all of them still follow the same pattern. Now there are multitudinal causes of weight regain after bariatric surgery. It's not a simple, straightforward, finding out the cause and just treating it. You have to take a careful history and ask about, you have to go spend a lot of time asking about the dietary habits of the patient, what has changed, what they were doing, how strictly they are now following it, how much they have relapsed. Very rarely you are able to identify, a clear-cut cause like anatomical, like a pouch dilatation and or a widening of the bypass anastomosis that we do between the stomach and the bowel. So that is when the gastroenterostomy anastomosis widens, and those are surgically correctable causes, and you offer a surgical procedure, and again the patient goes ahead on his weight loss journey. But most of the patients, there is a combination of, behavioral, medical and metabolic factors which are going to bear. There's a whole list of things. We don't need to go into the detail of all these causes. There are various risk factors who are likely to gain weight. Often we are able to guess pre-operatively. When we are counseling the patients for surgery, we are going to know these are the patients, who are going to be less likely to get very good results. Typically, patients are very much food-centric. Khava pivana bahut shaukin hai. They are fond of eating. They'll talk about food. They'll talk about the best eateries. They know all the food joints. They know all the great food items. Those are the patients who are going to be much more likely to relapse. Compulsive sweet eaters, those who give you history that they cannot pass any meal without having at least some sweet in the dish. Those are again likely to relapse, much more likely. So these are the patients we try to avoid, offering outright surgery. We do a lot of counseling before, we actually take them for surgery. We ask them to, give up their compulsive sweet habits, eating habits. We ask them to, switch to simpler diets, eating only at home. And if they follow that for 3 to 6 months only, then we take them for surgery. So as I said, there are a lot of factors, and there is also interplay among all these factors. It's not just the eating behavior. The eating behavior also changes after once you do bariatric surgery, and this will also affect the change. There will be a changing appetite. There will be a changing their eating patterns. The food intake may decrease. It may, give them a sort of thing that now, because they are eating less, they won't have the energy to do more activity. So they become even more sedentary. So those are the things that you have to go into and correct. Typical psychological causes of weight reduction which affect the eating pattern. They are very, very typical eating behaviors which are known as, as I mentioned, compulsive sweet eating. There is something known as binge eating. Patients follow a diet for a long time, then suddenly they'll relapse, and over a week they'll keep on eating a lot of food over the weekends, or they'll be grazing, continuously eating. When you tell them no, they were able to eat small meals. That's typical what we tell them, that you have to take 4 to 6 small meals rather than, sitting down to eat for 1 or 2 meals a day. They will keep on eating continuously. That's known as the grazing behavior. Alcohol dependence or substance abuse is very strongly correlated, of course. And depression itself, which is again very much common in our morbidly obese patients. And we have to correct that pre-operatively before we surgery. Otherwise, these are the patients which are sure to relapse and going for weight regain. There are also hormonal causes. Once you do a surgery, you're altering the anatomy. Various surgeries, sleeve gastrectomy is the least alteration in the bowel. But any other bypass procedures that we do, and there are a lot of them, duodenal switches, there are SADS, single anastomosis and bypass, a lot of things that are done. So when you change the anatomy of the intestinal tract, the passage of the food, It causes a lot of hormonal imbalances, and I'm talking about the gut hormones, not the typical endocrine hormones. So the GLP-1, you have the peptide YY, leptin, ghrelin, all these hormones will keep on changing, fluctuating, and they have all different effects on the appetite as well as the eating behaviors of these patients. After a bariatric surgery, typically our diet is that we ask them to take a high protein intake up to 1 to 1.5 kg body weight of the ideal body weight of for their height per day. We ask them to limit the sugar less than 25 gram per day, and encourage them to take foods with low glycemic index. I'm sure there were a lot of detailed nutritional talks where they would have talked about this, and divide them over 4 to 6 meals. Patients are happy to do this for 1 year, 2 years, 3 years. Then after 4 or 5 years, it becomes a little difficult to adhere to it, and that is why typically we see the weight gain happening after 2 years or so, because they are not able to stick to this protocol. They don't really have to remain hungry, but they have to just follow a regulated diet. It requires a bit of self-discipline for this. So what is the pharmacotherapy? What is the treatment options, medical treatment options? I'm not going to talk about the surgical options. Of course, we started off with orlistat, then we had different drugs, and finally the new kids on the block are the GLP-1 receptor agonists. So orlistat is basically an intestinal lipase or inhibitor, the most commonly known. Even the patients often come before surgery. They say that they are taking orlistat for trying to reduce weight. It blocks the intestinal fat absorption by around 30%. But now we know that it's not actually just the fat that is causing the weight. It's also the carbs which are causing the weight, and that is why orlistat never had a very good run. Helps in reducing about 5 to 7% of the weight, but never reaches about 10% of the total body weight. And the side effect is that whenever the patient takes this tablet, he lands up next day with steatorrhea, because that fat, and as a fatty meal, he lands up with steatorrhea. So that's sometimes troublesome side effect for this. Cost is of the therapy would be somewhere around 3,100 rupees per day, so about 3,000. That's affordable. But only problem is that the weight is maintained, or weight is not, as long as the patient keeps on taking the tablet. The moment patient stops the tablet, again the weight regain occurs. Then we had this phentermine topiramate. Again, these were centrally acting anorexogenics. These were to be taken once a day. We started off, this combination was to be started off at lowest dose and then gradually titrate it up. I'm not going to talk about this in detail, because this particular combination is not available in India. They are available as separate drugs, but they are meant for other indications, and the particular combination that we want in the dosage is very difficult to get, because it's usually you get phentermine as a 20 milligram or a 10 milligram tablet, or a topiramate as a 25 and 50 and 100 milligram tablets. So it's very difficult to titrate and give them separately. So usually we don't prefer this drug. Naltrexone and buprenorphine, these were both, again, they had more of a side effects as anorexogenicity was a side effect of these drugs. Naltrexone originally was and is still used in the management of alcohol dependence by psychiatrists, while bupropion is one of the drugs, antidepressants that is again by use. Again, you need a combination of 8 milligram of naltrexone with 90 milligram of buprenorphine, and then you can gradually increase it up to 32 milligram of naltrexone and 360 milligram of bupropion per day. Combination again is not available in India, but we get them as separate tablets, and we can titrate them and give this in the tablet form by dividing the tablets. So I've used these drugs often previously. After GLP-1 RAs have come, the use of this has decreased. Again, it costs about 200 rupees, for per day. So it's around 4 to 5 or 6,000 per month cost of the patient, and no fixed duration. As long as the patient keeps on taking the tablet, they have good effect. This is the new GLP-1. So just how this came up as GLP-1 was that it was found that GLP-1 was the one hormone that was greatly affected by bariatric surgery. Both fasting and postprandial GLP-1s are lower in patients with obesity as compared to those in normal weight surgeons. And when you subject these patients to bariatric surgery, GLP-1 rises, fasting GLP-1 rises, and not only that, the postprandial rise in GLP-1 is much higher with bariatric surgery than in controls. So it was, and this rise was found, start very soon after surgery, just 2 or 3 days post-op, and then it's even persisting after 1 or 2 years after surgery. So it's more of a long-term effect. And what was found that the patients who had more effective weight loss and the patients who are not regaining the weight had a sustained and higher levels of GLP-1 as compared to those who are regaining weight. Those who are regaining weight, it was found that after initially rising the GLP-1, it was again dropping down. And that is how we got GLP-1 receptor agonists in the treatment armamentarium for weight regain. 3 drugs are available: liraglutide, semaglutide, tirzepatide. It's going to come. It's not yet got FDA approval for weight loss usage. Lira and Sema are already approved for weight loss for different dosages as compared to your typical use in diabetes management. So the dosage of liraglutide was 3 milligram per day, and semaglutide is also available in a tablet form, but it's also available as a weekly injection. The weekly injection is not yet available in India, but in the West that has become the rage. I mean, you are all hearing about the brand name Ozempic and a lot of that. It's just become like, it's become greatly popular. And you have to escalate the dose gradually. You start off with 0.25, then 0.5, then 1 milligram subcutaneous. It has to be taken subcutaneously every week, and 1.7 by these are for every 4 weeks you raise it, and 17 weeks onwards you make it your 2.4 milligram, and then the patient has to continue this. Again, we don't know up to what time it had been given. The trials have shown you can safely give it at least a year, at least more than a year. 62 weeks, 68 weeks they have been given, can be given very safely. Not yet approved for children, young adults. There is risk of teratogenicity. So obviously pregnancy is not, you can't give it in pregnancy. In animal models, it was found to cause higher incidence of thyroid C-cell carcinomas. So patients who have family history of thyroid cancer and patients with MEN syndrome, multiple endocrinal neoplasia syndrome, having a family history of that, you don't give these drugs. You get about 5 to 10% of the weight loss after 16 to 24 weeks of therapy. So that is fairly effective, especially when the patients, you have just done a surgery and patients are regaining weight. So that has become that. Only issue is a little bit of the cost. Different brands are available. The original brand with Novo Nordisk is costlier. There are other analogs available from other companies which are cheaper. But most of the research has come from the original brand, right? And the tablet cost is lower. It's about half the cost of the injectable, but then the tablet has to be taken daily. So 2 definite adverse effects that you have to tell the patients when you put them on all this GLP-1 RA. One is in male patients, higher incidence of impotence is noted with the use of semaglutide. That has been definitely shown, and they gave it for now for all the GLP-1 RAs. And recently there were a lot of news reports of higher incidence of sudden onset blindness, that has been called non-arthritic ischemic optic neuropathy. The incidence is very low. I think 0.2% has been reported, but then it's with the increased use of semaglutide, we may get a revision in those incidents. So these are the 2 things that you always have to warn the patients about. What has been found is that combination medications were always effective, and GLP-1 RS have been found most effective among all the options that are available. So how do we weight loss? Again, not only dependent on the type of surgery, but if you started the weight loss, these treatments earlier, when the patient hit that nadir, on that graph where I showed you, that the patient had weight loss, then stabilizes, and that was a nadir, that's a fair amount. You get about 3 to 6 months time where the patient is now no longer losing weight. And then gradually starts. If you get the patient at that start and start the patients on this treatment, the results are much more better. So what choice of medical treatment among all these things? Orlistat is practically gone now. Nobody uses Orlistat. Only place where you use is a patient has got sufficient. He's happy with the weight loss and all that, but he tells you that he's a touring job. He has to go frequent social functions. He has to eat out frequently in the hotel. In those cases, you tell them, okay, before you go out on that day, you take this tablet. Next day, you're going to have steatorrhea, but at least your fat absorption may be less. So that's a very niche patient base for that. Otherwise, always we go off with a GLP-1 RA, semaglutide is the drug of choice. Those patients, then you look at the, other things also, patients already having migraine because topiramate is a treatment option for this thing. You may choose a topiramate phentermine if you can get it. Of course, since we don't get it, and when GLP-1 RAs and topiramate phentermine are contraindicated, you may give either a combination therapy or a monotherapy with bupropion or naltrexone. Finally, option is, of course, the surgery, revisional surgeries. There are different options for revisional surgeries that we do. That again is a whole separate talk, and it's not meant for a year. That's out of the purview of this talk. Thank you so much for a patient hearing. I'm right in time, I think. Thank you so much.